I would like to yet again thank Ash for highlighting some of our quantitative decision analytic modeling work. It's an honor to be here with you today. And so here I'm presenting Yale and Harvard and Emory University collaboration now. And it's entitled The US-wide red blood cell allo-antibody exchange can decrease mortality and be cost-effective in the care of alloimmunized patients with sickle cell disease. So what is the rationale here? So on the left, you see a red blood cell, and you see all of these antigens on it. And just think about it as, you know, potentially you can think about it as soldiers or something that just triggers the defenses of the body, right? And so then the body, the immune system has to recognize what's self and what's not self. And things that are not self can look problematic, especially when we get, let's say, a red blood cell transfusion. It's usually not from yourself. And so in that context, then you can develop an immune reaction, like a defense reaction, if you want to call it that. And if you see on the right panel, this is just a cartoon graphic that was published by my colleague, Dr. Jeannie Hendrickson, last year. As you develop this defense, over time, the defenses can wane. Those antibodies, like the V-shaped antibodies, can wane, and they can go below a certain detection threshold. And so that could be a dangerous period, and it can happen up to 81% at any given point for somebody who has been exposed to someone else's blood in the past. So then they are effectively at risk for having a reaction when they are yet again exposed to, let's say, a blood product. So my colleagues came to me and said, you know, I think it would make a lot of sense if we can make the case for an allo-antibody data exchange. And we think that it could abrogate this component of increased risk exposure to alloantigens, so to the soldiers that are not yourself, in individuals requiring blood transfusion. The transfusion burden for patients, specifically we ended up picking the sickle cell disease patient population because they get a lot of transfusions, but they're not the only patient population that's affected here, as I'll touch on in the end. And so here we know the transfusion burden is quite high, and actually we have pretty good estimates in this patient population in the United States. It seems that up to 44% of these individuals, of our patients, may be alloimmunized. And so then they are predisposed to, when they need a blood transfusion again, to something called a delayed hemolytic transfusion reaction, where you go into breaking down the red cells that you receive, and on top of that, you can actually start breaking down your own red cells as the immune system over-revs. These can be deadly. So what do we do? So to make the case for a national level allo-antibody exchange system, especially in this country where we're not very good at preventative care, right? We're not very good at catching things before things happen, and then we all end up thinking about medical bankruptcy, right, on the highest rate in the world here in the United States. So this bringing us back, thinking about prevention. This is a state transition diagram, and this is for with and without exchange. Without exchange is the current world that we live in. So, and the exchange again is this information exchange, right? Right now, patients can go to any given hospital, get their allo-antibody will be identified, but then in the future they'll go to a different hospital, and that data access will not necessarily be there in our country. So with this, you can see here the way that the model works is we take patients who we already know have been alloimmunized, and we know that they have this risk and possibility going to the right, highlighted in yellow, of DHTR, delayed hemolytic transfusion reaction. And so they can develop this DHTR. And so if they develop a DHTR, there's always the risk of DHTR-specific mortality, which I'll get to in a couple of slides. But the best estimates that we have are from big prospective and retrospective data, and the case fatality rate seems to be about 11% for these individuals who do develop a DHTR. And of course, in the background, you can also die due to background mortality, so non-DHTR mortality, whether that's sickle cell mortality or whether that's mortality from something else entirely. Here we used age, gender-adjusted QALYs informed by published lifetime simulation of patients living with sickle cell disease and matched controls. And methodologically, these were derived from EQ5D data that links to visual analog scale, specifically for patients experiencing sickle cell disease pain, which has been done in other studies. And then separately, age and gender-adjusted costs informed by 10 years of data from OptumRx, with the assumption here of a 50-50 mix of women and men, because women and men in all populations do have slightly different mortality probabilities. And so here is the DHTR incidence and DHTR-specific mortality. And I've just highlighted for you with a little caption and the arrows down of what can we see in a world where we have an alloantibody exchange, knowing that this alloantibody exchange is not going to be perfect. It's not going to prevent 100% of these reactions, but it seems like from the data that is out there globally, we can probably prevent about 60 to 70%. And so here, actually, you can see first, with alloantibody exchange, we're able to, over the course of lifetime, so on the x-axis you have years, and it starts at age 5, and then on the y-axis you have probability of having that event happen. And so we can decrease not only the probability of the event happening, which is the big hump coming down, but also mortality over the course of lifetime. And with this, we can gain about, if we're talking about a patient population that's about up to 44% alloimmunized, we don't want to take the upper estimate. We're going to take a range, a plausible range that we know from the literature, let's say 20 to 44%. So at that specific range, if 20 to 44% of our population is alloimmunized, we can gain up to from anywhere from 7,000 QALYs if it's 20% to 15,000 and change QALYs if it's 44% with exchange versus without. And I would say this is one of the two money slides, and I'll explain it briefly. This is a sensitivity analysis that actually captures the cost of an exchange system on the x-axis, going from $0 all the way to, you read that right, it's $500 million, and the population, which goes from 0 on the y-axis all the way down, all the way up to 44,000, which is that 44% that I talked about. The CDC estimates there's 100,000 individuals living with sickle cell disease in this country. And so you want to see, well, how much can we essentially decrease, how low do we have to get in terms of a population for this kind of system to still make sense? And so with alloantibody exchange, you'll see that everything that's blue is where alloantibody exchange makes complete sense. And what you should pay attention to is the x-axis here, because everything that's in red encompasses costs of this kind of information data sharing system of at least $50 million and goes upwards from there. And so for the plausible costs for this kind of system and for the plausible estimates of the population, we see that the alloantibody exchange is going to make a lot of sense for our patient population. So this is a probabilistic analysis where we take all the parameters and we vary them all at the same time. In three-dimensional space, we're essentially tugging and pulling at the model. On the x-axis, you have the willingness to pay. On the y-axis, you have % iterations that are cost-effective with versus without alloantibody exchange. And the exchange is preferable in 100% of 10,000 iterations at a willingness to pay of $100,000 per quality-adjusted life year, which is the commonly accepted threshold in our country. And this is the incremental cost effect in the scatter plot. So it's done in a nice visual way here. And again, you can see that exchange is preferable in 100% of iterations, no matter how much we stretch and pull of the data. So in summary, we can gain up to 15,000 and change QALYs for our patients with sickle cell disease if alloantibody exchange can be realized in this country. A net monetary benefit increment of $0.7 billion is what we would gain as a society. The lifetime operational cost, this goes back to the two-way sensitivity analysis I showed you with that crosscut of blue and red. The lifetime operational cost of such an exchange can actually exceed $600 million and still be cost effective at a conventional willingness to pay, right, over the course of lifetime. And finally, benefits of targeting data fragmentation will additionally benefit alloimmunized patients well beyond patients with sickle cell disease. So everything that I showed you and the benefits that I showed you are only for one patient population, but such a data exchange would actually benefit patients with other diseases, including autoimmunity, even our patients who are pregnant for any reason that you are exposed to alloantigens in blood transfusions, myelodysplastic syndrome and beta thalassemia. None of those conditions are accounted for here, and so the benefit to society would be significantly greater if you include those. So with that, I would like to conclude. I would like to thank my co-investigators, Dr. Ronald Hauser, my postdoc, Sadako Ito, Dr. Chris Tormey, all at Yale, Ankur Pandya, one of my close collaborators and colleagues at the Harvard School of Public Health, and Jeannie Hendrickson, who just moved from Yale to Emory University. Thank you very much, and I'd like to thank again Ash, Yale University, Yale School of Medicine, Yale Cancer Center for supporting our work. I look forward to our Q&A period. Thank you.